Thank you, everyone. All right. So first off, I just want to thank the entire committee. I'm the chair. I'm Allison Caban-Holt, and I'm the committee chair. I started back in January of this year after Elise Cook retired. And so I've been chairing for a little while now, probably all of COVID. So, and I want to thank the committee membership for really being an excellent resource as we are looking at recruitment and diversity in our clinical trials. So I just wanted to provide the names of our committee members, and I wanted to highlight that those who are in green are some of our recent members who joined us, including Desiree Walker and Jeffrey Berenberg. And so take a look at our committee, and also our colleagues who are members of NCI or NIH. So we've got Pete Castro join us, and as well as our SWOG staff. I really wanted to emphasize our guiding principles on trying to make sure that we always come back to these and remember our purpose. And our guiding principles for the Recruitment and Retention Committee is to utilize our expertise of the committee members to assist in clinical trial recruitment and retention efforts, and also to try to recruit and retain minority patients, as well as people who are of other categories as well. Just that we want to make sure that our pool of patients is as diverse as possible, so that we can do the best science that we can. We also want to diversify SWOG membership and leadership. So if we are ourselves not diverse, in diversity, we can talk about the different kinds of ways we can be diverse. But if we're not diverse, it makes it less likely that we're going to be able to share different perspectives and different ideas for solving some of the issues that we run into with regard to recruitment and retention. One of our primary goals right now is to get some idea of our baseline demographics for SWOG members and leaders, so that we can really understand where we are and where we need to go to. So we do have a diversity and inclusion focus, especially this year, with regard to, we want to go back to attention to the metrics that our Recruitment and Retention Committee had put together a couple of years ago, and see how we're doing on those. Those metrics do include understanding SWOG membership and leadership, diversity and inclusion, and how we are going about finding, adding to that. We're going to be working with a number of teams and colleagues to get a good idea of how diverse the SWOG leadership and membership is. We probably have not been asking the questions that we need to ask in order to be able to provide an idea of what our membership is. And so one of our goals for this coming year, and really just the coming months, is to work with leadership to find out what our membership and leadership looks like, and to set some goals for next year. I wanted to point out that we've also been collaborating with other committees on a lot of interesting efforts. We've been working with the Digital Engagement and Patient Advocates on a Hope Foundation proposal, and that proposal is looking at diversity and inclusion in SWOG, keeping on the theme, and we applied to get some funding for the development and implementation of some training on diversity and inclusion, with a focus on leadership as well as young investigators, because we do believe that that kind of inclusive thinking starts from leadership, and those values are invoked as the leaders help with the as the leaders give their message to their teams. So we think that leadership and PIs and research teams are really where diversity and inclusion start. We also have collaborated with the patient advocates to contribute to the Team Science Module 6 and training guide. So I've asked the team members to contribute, and that's been great, especially with regard to how patient advocates can advocate for inclusion and diversity in the patients that we serve. We're also going to be working again with multiple teams to set our goals for membership and leadership diversity. This year, we also had some excellent presentations, which is great, and we want more of those. If you have ideas for presentations that could be a part of our fall and spring meetings, or presenting on our team meetings that are the last Thursday of every month, we'd really like to hear from you. Kate Castro did at our fall meeting, in April, did a great presentation on de-implementation science. And at our last meeting, Dr. Robert Krause presented S1316 and the efforts for accrual in Latin America. And that was really enlightening about how some of the efforts and the implementation had to change in order to accommodate the various different Latin American countries and the different languages. So that was interesting. And then today we're going to have a presentation from Comar Figueroa Mosley about minority recruitment and end-course studies. So we have been having some really excellent presenters sharing their expertise with us. So in terms of future directions, I just wanted to say that diversity starts with us and our thinking, and those of us who are, we're leaders in this area of clinical trials in cancer. And so diversity, inclusion, recruitment, all of that really starts with us. And for the coming months, we'd like to set the goals for diversity in SWOG, in line with the SWOG strategic plan, which includes efforts for inclusion and diversity. I'd like to have our team really more fully conceptualize what diversity and inclusion looks like, that diversity and inclusion is not only racial and ethnic, but as well as other concepts. And I really want to make sure that we're giving attention to many different types of diversity and inclusion. I'd like to make sure that we're linking the importance of diversity and inclusion to our recruitment and retention efforts. That if we are not engaging a wide group of participants in our research, that we need to look at how are we reaching out to those groups, and if there are particular strategies and particular issues that we need to look at so that we can be more inclusive. We are planning to offer some trainings next year on diversity and inclusion, so please stay tuned to that. And we have, and a major goal is looking for a system for this team to provide consultation to PIs and young investigators. So we have been doing this a little less formally. Our team does provide feedback and does provide consultation, but the way that we find out whether the consultation was taken or whether the strategies were used and what the effect of those strategies were, we don't have a system that captures all of that. And that would really be important for us with regard to adding to the field of recruitment science and being able to publish and these types of findings. So we're in the process of trying to develop some sort of system um, for for consultation, as well as for it to be a feedback loop, so we understand what methods and strategies are working, so that we can provide better feedback, and so that we can enlighten the field as to what we're the best strategies for recruitment and retention. And that was it for me. And I thank everyone for joining us. And if there are any particular questions, please feel free to unmute yourself and ask, or if you want to share. All right, so I'm coming out of this. All right, so it looks like if there are no questions, then our the next item on our agenda is Colmar Figueroa Mosley, who is going to present minority recruitment and ending course studies.
Good morning, everyone. Can everyone hear me?
We can.
Okay. Before I begin with the presentation, the Recruitment and Retention Committee would like to learn more about our SWOG meeting participants. We will be asking 2 questions now and 2 questions at the end of the presentation. Can we cue the first question through WebOS?
Pulling it up now.
Thank you.
It's asking me to do this manually right now, even though I had it preloaded. So thanks for your patience, but here it comes. First question.
So the first question asks, who are our participants? Please mark who you are, whether you're a CR nurse, researchers, patient advocates, site managers or administrators, or other, and press submit at the end.
There are a couple of questions in the chat. One is if they're unable to access polling, they use the chat box. Is there a way to put the poll in for them? And another question was, which category would CRAs be in?
Would CRAs fit under D or other?
I would tend to, it could go under D or other.
It looks like we have the majority of participants' responses.
Okay, wonderful. Thank you. I guess we can go also to the next question.
Casey, do you have the next question?
I do. This system is just a little bit cumbersome for me, and I apologize. I'm trying to navigate there. So
Yeah,
did
no,
you
that's
see
okay.
the poll results when this? Were you able to see those poll results?
We don't see it yet. Okay,
There they
it's coming up. Okay, there they are.
Here they go. They're up
so
now, Casey.
Thank
The
you.
majority of our participants are others, with followed by site managers and CR nurses.
And next question.
The next question asks, what SWOG sites are our participants from? Please submit your answers.
Waiting on a few answers. There's a couple of chats. Somebody'd like some clarification on SWOG site.
So in terms of SWOG sites, I believe we're talking about in-core sites, but Allison, do you have any perspective on this? Would you also include SWOG sites, other study sites as well that aren't in-core?
Let's see. I would say we should cover all, we should include all sites.
Okay, so all sites.
And we did have in the chat that some folks were saying that they checked multiple because they're aligned with multiple sites, urban and suburban and rural. And we also had some folks who said that they do not, they would not specifically align to a site.
Okay, So Casey, can we now see the results?
Yes, let me show the results here. You should be able to see the results.
Yes, so with the majority of our SWOG sites coming from urban areas and will followed by rural and then suburban areas, with 30% having no answer to it, possibly because they covered a myriad of different arenas. So Casey, can we cue up the presentation now?
Are you able to see it?
Yes, I am. Thank you
Great.
very much. Are we able to put it on full screen?
Is that
Thank you, everyone. Yep, we can see it. Thank you.
great?
So today I will be giving a brief presentation of my NIH-funded qualitative study examining minority participants to CCOP research studies. In-core studies were formerly CCOP studies, so that is the change of the vernacular. Slide 2, please.
I'm so sorry here. Let me.
Thank you, Casey. This research emerged out of census trends suggesting that the United States is undergoing a change in its demographics. By 2045, the US will become minority white. Next slide, please. These changes will ultimately affect the way we do business in clinical research. It will be up to us as to how we acknowledge and implement plans to keep our research relevant and compelling to all populations. COVID-19 has exposed many institutional vulnerabilities as well as provided opportunities for growth. Next slide, please. This graph shows minority participation in NIH phase 3 clinical trials between 1990 to 2000 and from 2001 to 2010. Next slide, please. What we take away from the previous slide is that participation of people of color in clinical trials remained small. There was a noticeable decrease from 2001 to 2010 as compared to similar period from 1990 to 2000. And then although Black participation has decreased in phase 3 clinical trials, there has been a notable increase in participation in prevention trials. Next slide, please. So for my present pilot study, I wish to examine the factors that present barriers to participation, as well as understanding the components that support greater recruitment and retention. Next slide, please. The study sites included areas across the United States. Participating in core, former CCOP sites at the time, were chosen based on an openness to be introspective and a willingness to participate in the pilot. The participating sites included Wichita NCORE, New Mexico Minority Underserved NCORE, Montefiore Minority Underserved NCORE, Baptist Memorial Health Mid-South Minority Underserved NCORE, University of Rochester NCORE Research Base, and the Hematology Oncology Associates of CUNY. Next slide, please. In terms of demographics, our focus group participants were mostly female and mostly Black, with ages ranging from 29 to 78. There were 18 participating providers, of which 5 were doctors and 13 were nurses. Next slide, please. To be eligible, participants had to be adult, had to have minority status or be a person of color, and had no current substance abuse. We also mentioned that they had to have had or have stage 1 or 2 cancer. Next slide, please. We utilized in-depth interviews of providers, which lasted usually 20 minutes. The questions of providers pertain to site recruitment and retention practices. Focus groups were 1.5 to 2 hours in length, separated by ethnicity, and focused on beliefs concerning their cancer and their perceptions of medical research. Interpreters were provided for Spanish-speaking participants. Next slide, please. For our focus groups sessions, they were comprised of 3 components. First, an introduction and warm-up, followed by the introductory question, which dealt with telling a little bit about their health and how long they had been coming to a particular hospital, and then questions concerning their perceptions of medical research. Next slide, please. Provider questions focused on barriers to not recommending clinical trials, reasons for representation of people of color in clinical trials, and site efforts to increase participation and lessons learned that would be helpful to other groups. Next slide, please. In terms of analysis, the six focus groups were analyzed from verbatim transcripts of audio recordings of nearly 18 hours or 1,080 minutes of recording. The program Atlasti was used to guide coded analysis. We used grounded theory to guide our analysis and triangulate our work with other studies. For our providers, we analyzed their verbal and written responses. Now on to the results. Next slide, please. Next slide, please. The top themes amongst Blacks were, next slide, issues surrounding Tuskegee, which highlighted the beliefs that one best summed up these views from the quote, "I don't remember what it was, this group of men, that they did this research job, Tuskegee. And see, when it comes to Black people, that's where we go, you know." So Tuskegee was one aspect of what was one of the top themes. The next slide, please. Trust was another issue that was topping the list for Black participants in the focus groups. Really compelling was reading both of these quotes, but really zeroing in on the trust issue is what one participant said is, what I look at in a doctor is not in his ethnicity, it's humanity. When I listen to him, do I trust what he is saying to me? Do I have confidence in him? Because if I don't, I'm never comfortable. Next slide, please. Medication concerns were also major issues amongst Black participants in the focus group. They had mentioned about the Vioxx trials for pain that was later shown to increase risk of cardiovascular events. such as stroke and heart attacks. And so with this particular participant, they were really leery about joining. And after finding out about the VIX, particular VIX adverse adverse conditions that had occurred, they ended up being happy that they did not participate in the particular trial. Next slide, please. Also, there were concerns over being seen as a guinea pig. Whether the research was concerned about the next research break, or they were truly had good intentions to with the people. For many, these beliefs come from deep-seated knowledge of Black experimentation that goes beyond the Tuskegee experiment. Next slide, please. The top themes amongst Hispanic Latinos that were in the focus groups, next slide, please, were language barriers. They found that there was a problem of the willingness of researchers to adapt and provide interpreters and translators throughout the process. So one focus group participants said in the Spanish focus group, because sometimes we need to adapt to, I'll say Spanish Latino, because that is what I am. That's where I came from. But you need to adapt to the language barriers and their culture in order to get proper research and to let them participate in places like this. Next slide, please. The other concern was insurance status. Patients would report receiving a bill from the research study, and because of this, not returning to the study. And this is a quote from one of the participants, where it says, "I wonder also if it's economic, in a sense that a lot of our poor people live in small towns and they don't get into medical care, and this is really bad. And then by the time they get there, they are beyond the point where they could be helped. But they also, maybe there is financial barriers too, you know. They would say, come back for tests, and they never come back for the test." Next slide, please. So what do participants want most from the research? Next slide, please. They want more information about and education about the clinical trials process, and they want to arm themselves with the knowledge they need to make appropriate decisions. This quote highlights what a lot of the participants were thinking. And even educated very well. Everybody needs to be educated as much as possibly can, to know about the circumstances or anything that they can go through, to give them information that would be most helpful, that would be most appreciated to not just us, for everybody, so we can know what is going on before we go into the hospital or after we get out. Next slide, please. So in terms of provider perspectives, the reasons for minority underrepresentation included issues around trust, access. I think we need to back up one slide.
I am trying to navigate to that. This is the slide. This is the previous slide.
Okay, so we can go forward then.
Okay.
So amongst providers found that the barriers for recommending clinical trials was a history of no-shows, insurance status, the cost of conducting the clinical trials, the patient's fluency in English, the comorbidities, the current treatment regimen, and issues surrounding physician reimbursement, and also in regards to physician-patient interpersonal process is how basically how they got along with their patients. Next slide, please. Amongst providers, the reasons for minority underrepresentation in clinical trials included trust, access to care, the eligibility of participating in the clinical trials was too strict, the type of insurance, especially if a patient had Medicaid, and the particular participants' cultural and personal beliefs. Next slide, please. In terms of efforts to increase minority participation, providers said, most people don't ask. Also, that there's a great need to get involved in the communities at which they are providing care. Also, it is necessary to build relationships more than just presenting a research study, but actually knowing what are some of the major issues that may be of concern within these communities and being able to connect them to services. Next slide, please. So in terms of participation in research, we find that the top concerns influencing Black participation in CCOP, now in-core research studies, were Tuskegee, trust, medication concerns, and being seen as a guinea pig. The issues affecting Hispanic Latino participation were language barriers and insurance. But it was very interesting to note that the majority of the Latinos participating in the focus groups were unaware of the Tuskegee syphilis study. However, they did cite other studies targeting Latinos, especially ones surrounding a Texas blast study, which dealt with Latino military personnel. So that was something that had been mentioned in the focus groups. Next slide, please. So in conclusion, Black and Latino participation in clinical research and trials may be influenced by cultural, medical, and economic concerns. Both groups wanted more information concerning their research being conducted. The majority of Latino participants were unaware of the Tuskegee study, and many of the providers' various concerns were echoed in the focus groups. So, and also efforts to increase participation among providers were linked to infrastructure and relationship building. Next slide, please. In terms of limitations of this pilot study, it's a preliminary analysis to gather data about the problem of recruiting minorities and people of color into studies. Also, the sites that participated was basically a self-selection bias of both providers and patients to the study, and so there was no randomization to have them come in to participate. Next slide, please. In terms of future directions, what we might think about is an examination of SWOG and NCORE system-related infrastructure issues that may affect recruitment and retention of minorities and people of color to studies. There could be a possible implementation of health communication and health marketing pilots into NCORE studies. Also, what we as the SWOG Recruitment and Retention Committee have begun to do is create collaborations with SWOG patient advocacy that are inclusive of diverse populations. Next slide, please. In terms of acknowledgement, all this would not be possible without the cancer patients, and a team of these in-core sites that we see below, especially Wichita, New Mexico, Montefiore Baptist Memorial Health, University of Rochester in-core, and the Hematology Oncology Associates of CUNY. But most of all, I would like to also thank the SWOG team that were behind the scenes of Jennifer Macer, Whitney Leslie, and Casey Dawson, who without their tireless help, we would not be able to actually conduct this, have this presentation. Next slide, please. So at this time, we'll take questions and comments.
Hello, this is Bernard Parker. I'm from NIH, from NCI. And
yes,
I was wondering, first I want to commend you on that wonderful pilot study. That was very informative. And so I really enjoyed your presentation, very informative. I was wondering if within this survey, this study, this pilot study you were doing, if any question came up about having champions amongst the physicians that were involved with the studies. That is to say that based upon having attended recruitment and retention meetings, as well as other meetings, it appears that one element that is also encouraged is to have physicians within the area to serve as champions. And I guess one small other element possible, not small, but to have physicians, if you will, that look like the patients, and that would help to encourage that trust aspect amongst minorities, Blacks, Latinos. So so physician champions, if that's an element that came up in your study. And number two, to have physicians that are a part of the culture that could help to encourage or increase patient enrollment in your studies.
So what I noticed was that within this 6-site study, there was one study, especially like the Wichita study, and at that time, Marge Good was at Wichita NCORE, now she's at NIH, but she did she did have community members that were participants that were champions for the Wichita NCORE, because Wichita is in an area of Kansas that had in the past a very high recruitment of minority participants to the NCORE studies. And so it was a very interesting place to be, a place in the Midwest that was able to gather people from, especially Hispanic Latinos, to participate in their research studies. In terms of physician champions, yeah, out of all of these sites, the physicians were all white, but their nurses were participants that had various different ethnicities, and so I wish that there would have been some physician champions that looked like the participants. But I think one of the major take homes from what in terms of the study that I did was that it didn't matter what the ethnicity of the participating physician was. It was whether they could be trusted and whether people found that they could connect to that physician champion. So if that was the major underlying factor, whether they were Black or Hispanic, they would go to that particular provider.
This is Craig Nichols. I'm one of the SWOG executive officers. I was wondering, and this may be a little bit too granular for this pilot study, but were you able to determine what type of research they had been exposed to, whether it's local institutional research, pharma-sponsored research or what we're mostly about, which is federally sponsored research?
So in terms of the research that they have been, I guess, responding to would be mostly the NCORE CCOP studies at the time. But I noticed that amongst the people who were going to their primary care physicians, they had also, in addition to having cancer, they said, their primary physician had sent them. I mean, these individuals had comorbidities that may have, that also were on top of having cancer. So they may have had, some heart issue or had some other issues that they may have been referred out to other studies. But I'm not sure if they were referred out to other NIH studies that weren't cancer related, or if they were sent out to pharma studies, because that was not the focus of our studies. But what I have learned that from certain pharma studies, that if we're sending patients out of a particular state into another state, that sometimes there can be limitations in terms of how we may be able to connect these individuals in terms of understanding what's the underlying issue surrounding why they're not participating or why they are participating.
Okay, thanks.
Okay, Komar, there are several comments in the chat. One is, are the slides going to be available? Folks are interested in having their slides.
Yes, they'll be available.
Lucy Gansauer said, great presentation. It would be a good idea for NCORE to conduct focus group survey at each of their sites so they can better understand the views in their catchment area. Another question from Ron Brand was socioeconomic status considered? So
socioeconomic status was considered, but I think what we wanted to do in this pilot was to capture everyone that was able to come. And so if we had stratified by socioeconomic status, we may have missed people or had fewer participants. What we did in terms of the study, in terms of reimbursement and remuneration, was that we would provide travel costs for all the participants to get to and from the participating study site. So we were able to conduct focus groups there. Also, for some of the sites, we actually went to community areas like the Gilda's Club to actually conduct the research there. So we actually went to the participants if we needed to, moving things off from the medical site into the community.
Well, hi, this is Ron Brand. I just wanted to follow up because I used to work at Henry Ford Health System in Detroit in the public health science department. And socioeconomic status was a much bigger factor with us because if they were low income, we would send them cabs sometimes depending on the study. And if they were low income, they would see that like a limousine. You know what I mean? Like they would get excited like they were getting a limousine. So that's why I brought it up, is because it really seemed to be a lot more to do with socioeconomic status. And also when we paid participants, it also had to do with socioeconomic status, like what's in it for me.
Well, but I think we can look at a myriad of factors. It could be SES as well as race, as well as various different factors that I had mentioned already. I think maybe SES may have been the major issue within your Detroit area, but in other areas it may not have been. And so I think when people are treated well, they're going to participate. when they know what the study is for, and that they have a clear indication as to, this is what we're studying, and this is how you can help, and this is what's in it for you, in terms of better health, then it can come around to having better outcomes overall for everybody else, rather than approaching it as they're fortunate to be able to have a taxi to take to a particular location. I think it's, as looking at these issues, we need to be a little bit more open about knowing that beyond the financial part, that patients are getting better care, and that their participation helps improve care of all patients.
Okay, thanks.
Komar, in the chat, Wendy said, would the takeaway here be that Black patients don't trust the cancer system and Latinx patients can't access the system due to language or insurance?
Yes, that would be the great takeaway, and I think that there's, as we can see, that there's a lot of access issues within the Latinx community, and that there are two varying different issues that are approached, that we need to think about when approaching these communities. One is around trust, and one is around access. But also, African Americans may have access issues in different locations around the United States. These locations were locations that were willing to have us come to their site and willing to be introspective. When we actually surveyed, had an NIH meeting at NIH headquarters with 30 CCOPs, we only were able to receive participants from 6. So I think one of the things is that NCORE, CCOPs have to look introspectively to see, as was suggested by Lucy, to do focus groups at their sites to know what their population needs may be, and to have a better understanding of what are the issues, the underlying issues that are surrounding why we may have good participation, or why we may not have good participation in research studies.
Some work that I'm doing is going in the direction of looking at trustworthiness. That when we say that that patients don't trust, or it's almost putting it on the patient or on the participant, rather than flipping it around and saying, are we trustworthy? As you could see in a lot of your comments, that it was really about building this relationship regardless of who the participant is and regardless of who the physician is. But it's an important element. And what is it that we as researchers, as physicians, as professionals in the healthcare system are doing? How can we make ourselves as trustworthy as possible so that there can be a trust built? Is some work that I think that we need to look at.
I think we also need to consider that we're asking people why they didn't participate, what their barriers are when they, so these are the people that we've talked to. What we haven't looked at is our own internal barriers. I think there was recently a meta review of many studies, and they really found that more than 50% of the time, patients were not offered a study. So when we don't even offer them a study, they can't get on a study, obviously. So if we didn't have the right trials for them, if we were doing studies on the types of breast cancers that affected one population, but another population had a different type, and we weren't doing that kind of research, obviously we would exclude a lot of people and it was more than 50% of the time they weren't offered a study because there weren't studies for them, or they were just structural questions. I think we really should also assess our structural barriers and not just always ask the patients, why can't you participate, or why aren't you interested in participating? There's so many things that we ourselves are putting up as institutions that make it not possible for people before we can even ask them.
Thank you, Lynn.
This is Craig Nichols again. Sorry. Was a problem of paternalism or lack of shared decision-making discussions, or did those come up at all in discussions or surveys?
No, that didn't come up. I think one of the major amongst the providers, in terms of it, I think institutional support and institutional funding was a concern amongst these providers and CCOP heads at the time, that they may not have had enough funding to do a lot more outreach from their institutional support side. And so I think it's important that instead of saying that in-core studies need to just they need to increase their focus on minority populations, but we as institutions, wherever these institutions may be, need to think about how we approach patients of different groups and be able to be much more inclusive. I know that for some of the institutions that I have been at, like recently Mayo Clinic issued a $500 million initiative to confront these issues. And this is institutional wide, and it's looking at issues surrounding disparities and beginning to do more than just the window dressing, but really let's look at how, if we exclude people, it may ultimately affect our bottom line. And if we promote inclusion, and we find ways to expand our funding to include these various different groups, we can actually do better medicine. And I applaud Mayo Clinic for doing that.
All right. Thank you, Komar. The presentation was excellent. Thank you so much. There are other comments in the chat. We won't be able to get to everyone's comments, but please read them. There's a lot of good information in there and some questions to consider. We're going to go ahead and move forward with our agenda right now. The next part of our agenda will be reports. Kamara Mertavera is going to give this a quick update. Please go ahead, Komar.
Excuse me. Are we doing the last two questions to wrap up?
Oh, I totally forgot about those. Sure, go for it.
I'm pulling it up now.
Okay. So our session today, we wanted to ask the final two. Either your to the website and use the code. If you could answer, if when you think about the word inclusion, what does it look like? Pick a few words that, at least 3 words that what like. The to Mentimeter browser. Thank you. It looks like from the Mentimeter, inclusion means that, followed by diversity of all races included. So thank you for everyone's comment. And then Casey, can we the last question?
Coming up.
And so for the last question is, what future topics would you like to see on the recruitment and retention meeting agenda?
Looks like it's the same code.
Oh, okay. Very Thank you everyone for your responses. As you guys continue to respond, we will move on to the other parts of our committee meeting, and I will turn it back over to Dr. Cabin Holt. You guys can continue to answer in Mentimeter, and we will continue our meeting.
Thank you, Komar. This is great. Some really interesting answers and suggestions. Thank you, everyone. Okay, so we're going to go ahead and move on to our updates. Kamara, do you have anything for education?
Good morning. This is Kamara Mertz Rivera. I don't have any major updates because I know we're really focusing on the presentation. Great presentation. Thank you. I know we had proposed in the past that we were hoping to get some rural education maybe for the future on how to best kind of piggyback on really taking advantage of the telehealth and accelerating some of the possibilities of being able to reach some of our patients that are in the rural population and consenting them remotely. That's been, I guess if we can say, a silver lining with COVID, an increase. We've seen a lot of increased participation via telehealth and the use of remote monitoring. So that was something that we wanted to bring forward, and we can talk about it at our next meeting. But we do have some interest from others that are able to provide some presentations on that. And I know that we're going to go over our SWOG accruals, and I took a quick look, and it does look we have some increase. I know at our site with Upstate Carolina INCOR, we were able to increase some of our enrollment specifically to the rural populations, but not just that, also staff participants that otherwise weren't able to make it in. We were able to recruit them using a remote process. And I don't know if, Lucy, you had any other recommendations or comments, but that's our update.
No, thank you.
Okay, thanks, Kamara. I think we were talking about the details of doing the remote consent. I think that's something that would be a great topic for us to talk about more and how that's working out.
That would be great. I know that different sites might have some barriers for that, so maybe some shared practice and roundtabling on how we can make sure we can use that to continue participation in studies, and for protocols to consider that moving forward, that as part of the process.
Much agreed, and probably COVID has probably moved some of the thinking on that forward. We're probably problem solving on that faster than we would have been otherwise. Thank you.
Thank you.
All right, so next we're going to talk about the SWOG accrual update. Kathy Rankin has, so attached to the agenda and the meeting invite today, there was, you should have found attached the accrual update or the accrual, found an attachment with our accrual information. And Kathy Rankin could not be on the call today, but she did provide us some information and some insights about how things are going during COVID. Jennifer, would you be able to share what Kathy had shared? We can't hear you.
Okay, sorry, I was on mute. Yeah, the big news was that the report of studies is out, and as Allison mentioned, there's a PDF version that we also attached and sent out of the accrual chapter, which is especially relevant to our committee. Let's see, around the end of August, early September, the weekly accrual for SWOG trials was around 62 per week, so it's been hanging around that number. Overall, on average, let's see, we are at about 70%, 75% of pre-COVID accrual between both NCTN and NCOR studies. The majority of that is NCTN studies, and one theory with that is that a large accruing trial, S1415 CD, closed in April, so that actually brought in quite a few people. And then 1417 CD closed, I think, last year, but still that was another accruing trial. So NCTN is pretty close to pre-COVID numbers. NCOR is about 41% of pre-COVID, so it's a little bit lower. So that's all I have for that. But take a look at that after when you have a chance. It's interesting.
Thank you, Jennifer. I'd also noticed when I looked at the full report of studies, I did notice that certainly for phase 1 and 2 trials, that recruitment of people of diversity, of diverse populations was less than in phase 3 and 4 trials. So just something that I had noticed as I was looking at that. Thanks, Jennifer. We'll go ahead and move on to our reports. Oh, did someone have a comment? I'm sorry, I didn't mean to move on too quickly. Okay. All right. We're going to move to committee updates, digital engagement. Wendy, do you have an update you'd like to provide?
Yeah, good morning, everybody. My name is Wendy Lawton, and I am the staff liaison to the Digital Engagement Committee here at SWOG. And you'll see coming up here soon an update on one of the Digital Engagement Committee projects, which is a Hope Foundation funded project called Cancer Briefs, which is looking at using infotainment to raise awareness of and interest in clinical trials. And we're creating 3 different videos that Jonathan Summers will explain to you here shortly. So we're making progress there. The Digital Engagement Committee also last year took on a new task of reviewing all surveys conducted at SWOG, and we've reviewed several of those this year. But the big news out of the committee is sort of 2 things. And the first is the chairman, Don Dizon, has received some funding from Hope to engage some digital health companies and seeing if we can create some partnerships with some of these companies and test some of their tools in our SWOG clinical trials. And we've brought in a few companies. One is Doximity, which is a huge physician communications platform that enrolls a really huge number of physicians and particularly oncologists. And we're going to be creating a proposal to work with Doximity. And the one that's even farther along is a company called Aura. And I don't know if any of you guys have seen the Aura ring, but it's a wearable device. It's a ring that can track sleep, body temperature, and activity levels. And we've created a proposal that we will be putting forward to test that ring in a trial at SWOG. And so that's pretty exciting. And later today, when Digital Engagement meets, we'll be bringing in a company called Blue Note Therapeutics. And Blue Note is actually testing a behavioral health, a digital behavioral health program, actually with COVID patients, and they're interested in potentially working with us to do some mental health interventions with cancer patients and survivors. So we're going to be getting a presentation from them. And I think one of the things that we'll also be discussing today is a really big one, which is the mission of digital engagement. The committee's been around for about 4 years and has really evolved in terms of mission and goal. And we're going to be revisiting that and looking at what should the relationship be like. Is this connecting with companies a good way that digital engagement can serve SWOG by vetting companies and making introductions to investigators in the different protocol producing committees, and also looking at the potential for digital engagement to run its own studies. And so there's going to be some really exciting kind of big picture conversations that I think are going to be kicking off today and going on for the next few months in digital engagement as we look at our mission. And as I think that a lot of the research support committee missions are going to be looked at under our strategic plan. So I know that Allison will be working on that as well, because they've really evolved. And Dr. Craig Nichols, who is on this call, is SWOG's Executive Officer for Research Support Committees, and making sure that those committees are empowered as much as possible to do the best good for our trials is really something that we are going to be investigating in the strategic plan. So lots of really fun kind of big picture discussion in digital engagement right now.
Great, Wendy. Any questions for Wendy or comments? Okay, thank you. Next up is the patient advocates update. Desiree Walker, do you have an update?
So, good morning, or is it afternoon, depending on where you are at this time. And I just wanted to, one, acknowledge that I am new to the SWOG Retention and Recruitment Committee, and that also makes me new to the Patient Advisory Committee. So I'm going to just, briefly speak about two things that have been discussed recently at our meetings, and if there are any additional updates that Wendy believes I should have covered that I didn't know about. I'm going to ask her to be my side and make sure that that gets communicated. But what we have done recently in preparation for the conference this week was we had the opportunity to have Dana Sparks, the operations chief, come in to talk to us to help us prepare for the meeting that will be held a little later on today, focusing on the post-COVID innovation task force. And so she basically, let us know that, the mission was basically to see what lessons could be learned from COVID-19 pandemic. And that this task force was going to develop recommendations, and the patient advocate committee is going to be spending some time today to really talk about, what we believe are some of the areas that need to be focused on so that the changes that are going to be implemented down the road for SWOG and NCTN operations will be sure to make sure that we're operating efficiently, we're operating effectively, and what I also think is equally or perhaps even more important, that it is actually patient friendly. And so, it's a task force that has about 11 members, and Dr. Blanky chairs it. And it has a diverse group, and we're so thankful to have Barbara Segura Vasquez, who is on the patient advisory committee, to actually be a member of this task force. And so we look forward to contributing to the great work that they're going to do that's going to shape us for the future. But I'd also like to just highlight, because you, Allison, spoke a bit about this in your early remarks, is that we have actually taken a look at the DEI at SWOG. And so, we are looking to contribute to the changes that are going to be needed. And I think, the presentation that Colmar gave also speaks to a lot of the focus for all of us. Regardless of what committee that you're on. And so, Rick Bangs and Hildy Dillon have definitely, tried to assist the PAC group to really, try to think outside the box as it relates to the respective committees that we're on, and to really try to be part of the change that is needed at this particular time. My understanding is prior to my arrival, there have been many community advocates that have been added, but during my short time here, we've actually had the opportunity to add on a few more community advocates, which we were excited about because, talking about diversity, they're addressing the groups who traditionally are underrepresented in terms of the military, in terms of the young adult population, in terms of the older population, ensuring that the Asian Pacific Islanders are represented, and we also have a gentleman representing the African American voice as well. And so I'm going to stop there. I'm going to say, Wendy, if I've forgotten anything or didn't know about anything because it happened before I got here, please feel free to add in at this time. Thank you.
Desiree, you did great. You covered it all. I just did a little backup there and slid a link to the agenda book in the chat box so folks can see a picture of you and all of the 7 new advocates that we've brought on to SWOG in 2020. But that was a great summary.
Thank you so much. Appreciate that. And thanks again.
Thank you so much, Desiree. This is great. Are there any questions? Okay. Thank you. Next will be Jennifer Mazur, and we're going to do the NCTN Accrual Core Team update.
Okay, also known as the ACT team, or ACT. So the ACT, for those of you who don't know or aren't familiar, it's a group of people made up of cooperative groups. So SWOG, ECOG, Akron, Alliance, NRG, NCI members, and there's an opportunity on these monthly calls for groups to present their studies for discussion and input on accrual. So recently we've had 2 SWOG studies reviewed, S1914, and then most recently was Dr. Nichols' study, S1823. So those were both groups to present.
Hey, Jennifer, you're cutting out some.
Ray just talked about.
Hey, Jennifer, we can't hear you.
Last is that in October, SWOG will have the opportunity to lead 30-minute session.
It looks like Jennifer may have something going on with her connection. I'm showing that she's got a low bandwidth condition, local computer condition.
Okay.
This is Craig Nichols. I'll just jump in and say that my participation was very useful as a PI, and I got a lot of tips about communicating the trial broadly. I will say it also includes the Canadian Clinical Trials Group, but as a PI or an investigator, I highly recommend you participate in this, and it should help your study accrue better and quicker.
Okay, thank you for those comments. All right, looks like we're kind of lost Jennifer. Susan Rogers was asking, what study is he talking about in the comments? We can hear you now.
Jennifer, it might help if
I'm typing things into comment.
It may help if you turn your camera off. Unfortunately,
really? Okay, I'll turn my
camera off. But I think that might help. Yeah.
So the study was that S1823?
Okay, so yes, let me recap because I don't know, and I'll do this really quickly because we want to have a chance to see the video. So if you didn't hear me, the accrual core team is made up of cooperative groups like ECOG, Akron, Alliance, NRG. There are NCI members, and then there's an opportunity for study chairs to present their studies. So Dr. Nichols just mentioned that he presented S1823. Actually on our last call. So it's an opportunity to present the trial and then have a discussion and get some input on accrual strategies. We had also discussed S1914 a few months ago. And then the last thing I had mentioned is that there's also each group has a time to present a topic of choice, and our month will be in October, and we're hoping to talk about some of the post-COVID strategies that Desiree was actually mentioning in her advocate report. Okay, did you hear that? Okay.
We did, thanks.
We did.
Right. Okay, and I know Jonathan is on.
So I'm going to go ahead and pass the presenting ball to Jonathan to make the presentation.
Hello, everyone.
Hi.
Hello.
How's everyone doing today?
Good.
Good.
Thank you for letting me join. I am trying to start my video. Hi, my name is Jonathan Summers. I serve on SWOG's Digital Engagement Committee, as well as Patient Advocacy Committee and AYA. Jennifer has been helping me, as well as many people in this meeting today. with a project we are calling, I'm sorry, I don't use WebEx that much, that we are calling CancerResearch. It is a project that is Hope funded, and it's based on this idea of, can we use media and technology or infotainment to increase awareness of clinical trials. Just a little bit about me. I live in LA. I'm a Hollywood writer and producer. I work in digital entertainment. I'm also a cancer survivor that tried to use my experiences with cancer to help others. That being said, let me tell you a bit about the project. We were funded to make 3 different Cancer Brief episodes. Different in the sense that they have different goals, each one, and each episode has a different thematic element to it. So episode 1 is a kind of a new show about creating awareness on cancer clinical trials, specifically NCTN clinical trials. Episode 2, which I am going to be showing you today, which is a very, very rough cut, is about cancer disparities and can we increase awareness amongst these groups of cancer clinical trials. And the 3rd episode is looking to see if we could increase awareness of one particular cancer or SWOG trial. It's S1501, and that's going to be a faux kind of pharmaceutical commercial. That being said, I would like to show you the rough cut. Casey, if I'm given permission right now, I should be able to share my screen with you.
Right at the bottom.
Yep.
There's a share button.
I pushed that. It says connecting.
Alternately, you can throw the link in the chat box and I can grab it.
Okay. Oh.
Nope, we see it. Perfect.
Oh, great. All right. So this is, for people who might have seen this, this is episode 2, a very rough cut. My partner, Eric, who was working on this, came down with 103.7 fever yesterday and got tested for the virus. So he wasn't able to finish an output of the update, but here's the rough cut, and I hope you enjoy.
So we are not hearing any audio, Jonathan.
Okay, let me just put it in the chat then. My apologies.
I should be able to do this quickly.
So just some other things that we'll talk about afterwards. We are using metrics to gauge our success. And once I show you this video, I'd like to tell you a bit about the marketing that we're using, as well as how we're collecting on this to see if we're successful.
And before we get started, I need to this is what I want to do.
Jonathan, we still don't have audio for the video.
Yes, I think Casey's working on that.
Oh, okay. Okay.
Why don't I go over some of the marketing while we work on that, since we have this time. So for the whole campaign, we are targeting 50 million people in the US interested in cancer care as well as research. People will be reached through Facebook, Instagram, in-feed paid ads, including multiple formats, whether it's a mobile, desktop, video, static images, image carousels, and stories. We are launching the Thrive Cancer Network, where I work at TV4 Entertainment. The videos will also be posted there, and we will promote it through our channels that we already have a large following for. We are also looking for kind of organic social campaign elements, whether it is through and fitting through like tweets of SWOG, or whether it's through tweets of the Hope Foundation. As we mentioned, there will be 3 different episodes that we're hoping to launch all together. We've decided through DE that right now it's probably not the best time to launch, given everything with COVID, the elections. Just people really don't have the appetite to be really learning about cancer clinical trials when they're more concerned about COVID trials at this time. We are spending around $750 to $1,000 on each episode for marketing purposes. We are looking for about audience and impression of 3 million to 5 million. Some of our key primary KPIs: video views on Facebook and Instagram, ad engagement, likes, shares, comments on Facebook and Instagram ads, clicks from Facebook and Instagram ads to the full-length Cancer Brief videos. So kind of we're going to implement kind of teasers on Facebook that will hopefully inspire people to watch the full-length one, if that makes sense. Secondary KPIs are increased website traffic to the Hope Foundation and SWOG. We already have metrics of what the average clicks are, whether it is per month or a couple months or years. We'll be able to kind of see if there's been an increase in volume. Email signups through the Hope Foundation or SWOG, because all of the episodes end on, for more information, go to swog.org or the Hope Foundation, as well as any donations to the Hope Foundation. That obviously isn't our key goal, but if it happens, that would be wonderful. That said, that's kind of the marketing overview. If you have any questions, by all means, you can email me or we could address it here. But I really want to show the video. Casey, any success there?
Yeah, I think we are good to go, and I've got IMS standing by, our tech pros, just in case. So here we go. Let's try it again.
What does cancer mean to you? What's the first thing that comes to mind?
What do you think about cancer?
Cancer. That word.
What does cancer mean to you?
What's the first thing that comes to mind?
Being bald and sick.
Taking my grandmother to the hospital.
Chemotherapy.
It's why I became a doctor.
Hope.
A disease that's taken too many lives.
Wanting to cure all patients.
I've been through chemo and it hits you like a sledgehammer.
I lost my father to pancreatic cancer.
My dad was affected by cancer.
I was 24.
He was a survivor until he wasn't any longer. Every time I treat a patient with cancer, it's another opportunity to help somebody like my dad.
Cancer doesn't discriminate according to age, race, or ethnicity.
And cancer affects people of color at an alarming rate compared to the white population.
According to the National Cancer Institute,
Black men and women have the highest rate of getting and dying from cancer.
The disparity isn't just in the Black community.
Hispanics have the highest rate of new diagnosis for cervical cancer.
Asian and Pacific Islanders have the highest rates of stomach and liver cancer.
When compared to other races, Black men are twice as likely
to
die from prostate cancer.
But we can do something about it.
We can do something.
You can do something.
Cancer clinical trials.
Clinical trials.
There are many types of trials.
The National Cancer Institute, or NCI, is a publicly funded agency of the National Institutes of Health
that conducts many types of clinical trials.
Cancer clinical trials are how the medical community improves cancer treatment.
Trials lead to new medications, new ways to treat people, and new guidelines for care.
Every major treatment for cancer
was once tested in a trial.
The types of trials that the NCI runs includes treatment, screening, prevention, and supportive care.
They're done with close supervision and rigorous oversight to be as safe as possible.
They're done with the utmost respect for our patients on the trial.
Respect for the patient.
Certain types of cancer affecting minority groups differently.
We need trials that research this
and people to take part in them.
Because right now, very few
minority cancer patients
enroll in clinical trials.
By not being in these trials, we aren't reflected in the findings.
We need research and results
that represent everybody.
Everybody.
Trial enrollment
that's as diverse as a U.S. population.
So the medical community can find answers that speak to all of us.
All of us.
All of us.
In the Black community, there's been a long-standing distrust of the medical system.
And reasonably so.
From 1932 to 1972, the Public Health Service wrongfully and unethically conducted the Tuskegee experiment.
Black men were misled into thinking that they were being treated for syphilis.
They actually didn't receive any treatment.
People were not respected.
And people were seriously harmed.
But from this awful experiment
came many of the laws and regulations that protect people in clinical trials today.
Today, clinical trials follow strict protocols and ethical guidelines,
with protections in place to keep patients as safe as possible.
Especially those coordinated by the National Clinical Trials Network, or NCTN, and run through the government.
If we're going to improve cancer outcomes for our communities,
we need you. It starts with you.
You.
If you
or someone you know has cancer,
ask your doctor if there's an NCTN trial for you.
You just have to ask.
And go to cancer.gov to learn more about all of the NCTN trials.
So you can help improve future cancer outcomes.
In the Black, Hispanic, Asian, and Pacific Islander communities.
For more information on how you can be part of the change, go to
All right. I hope that gave you guys a feel of what it is. As you probably know, there's some celebrities in there, some average people, but we tried to get a very diverse group, and we are going to, all of that was made during COVID, meaning it was all done remotely, which was very problematic. We started filming this with the physicians. As you'll notice, there is a bluish background. That was a mobile set that we actually brought to their hospital and filmed with them. That was prior to COVID. What we are now doing, and it takes a lot of time, is everyone's going to have that same blue background. And we're in the middle of the editing process of it. But as I said, Eric, who's doing the editing, came down with what appears to be COVID, and I really hope it's not. But so if you have any questions, I hope, a lot of people on this committee helped with this, including Jennifer, Lynn, and others. I hope you enjoyed it. If you have any questions, please let me know.
Thank you, Jonathan. That was great. Does anyone have questions or feedback about the video?
There are some comments in the chat.
This is Marge with the NCI, the Division of Cancer Prevention. I got into this meeting a little bit later today because of an overlap meeting, but it's a very nice video. I like it. The NCTN piece kind of bothered me just a bit. Yes, NCTN does primarily treatment trials for the treatment of cancers, but you mentioned in there that NCI does prevention and survivorship, and we do symptom management studies as well. And those are funded and done through the NCORE. So I would recommend adding in NCORE into that, the NCI Community Oncology Research Program. Just for clarity, or else change it to NCI trials or something, so it's not just limited to NCTN.
Okay. I will also provide my email in the chat, so if anyone has any thoughts or questions, in the future, you can just shoot it to me. Does that work for you guys?
Yeah, Jonathan, we can also put it in the minutes and the call summary as well.
Fantastic. And as we have a cleaner version, I'll be sure to get it to you. But it was a lot of favors. You probably noticed like Gil Bellows was in it. He's a pretty well-known actor who was in Shawshank Redemption. And a lot of the other people are just famous writers, friends of mine that agreed to do it. Yes, production can be done during COVID, but it takes a little creativity. And thank you for watching, and I hope you enjoyed it.
Thanks for taking the time, Jonathan.
My pleasure.
There was another question in the chat that said, this was from Peggy Zuckerman, will there be a way for an individual patient to seek a clinical trial for his individual cancer, and how to capture that person and guide them properly?
Is that to me specifically?
That is what I was assuming.
Well, in this video, we don't mention, as we said, the primary goal of this was to increase awareness of cancer clinical trials among these underserved groups. It wasn't to promote a specific trial or to, we're not in a position to tell them which trial to go to. I think that's far beyond my pay grade. I'm here just to make content, and I wouldn't want to give wrong information. Our third episode is seeing if we could increase awareness of one trial. So that is S1501 with Dr. Floyd and, sorry, I'm blanking on her name, Dr.
Leha.
Thank you very much. So that is looking to increase awareness of that trial, but this episode is not aiming to do that. I hope that answers your question, if it was directed to me.
And Peggy, if that does not answer the question, why don't you, you can contact myself or Jennifer, and we can, if there's some way that we can help you answer that question.
And this is Marge again. That S1501 is an NCORE funded trial, not NCTN. So just as an example.
Oh, good to know. But in that, so that episode is a kind of meta cinema episode where we're kind of making light of a pharma commercial that's cliche. So in that commercial, within a commercial episode, if you guys really want to see it, I'm happy to send the script. It really doesn't mention NCTN trials, but it's good to know that it's NCORE. Thank you. And thank you to everyone who helped on this episode. I could have done it alone. So Jennifer, Lynn, there's probably 5 other people on this call right now that helped with this. So thank you very much.
Great. Thanks, Jonathan. It was good to see the video. That's great. Any other questions? I think we're at the end of our agenda for today. Jennifer, can you remind me the date of the next meeting?
October, well, it's just a strictly committee meeting. So for the smaller recruitment and retention committee, it's October 22nd, Thursday.
Great. Are there any other questions? I think we are at the end. I think we're going to adjourn unless there are any other questions or comments. Great. Thank you, everyone, for joining us on this meeting, and we'll be seeing you in the spring. Take care. Thank you. Bye-bye.